Welcome to the Rad-On Smart Review Head and Neck Cancer series.
Today, we're tackling a topic that is arguably the most distinct, high-yield, and technically demanding site in the entire head and neck curriculum.
We're discussing Episode 22, Nasopharyngeal Carcinoma Intro Anatomy, EBV Biology, and the definitive RT paradigm. And this is one of those topics that just feels massive. Nasopharyngeal carcinoma, or NPC, it comes up constantly on board exams and clinical discussions. It really feels like the examiners love this disease site. Why do you think that is? Why is this such a favorite?
I think it's a favorite because it forces you to think differently. If you approach NPC the same way you approach, say, a tongue cancer or a larynx cancer, you're going to get the answer wrong.
Okay.
It behaves fundamentally differently.
Sure.
First, it's a radiation-first disease. Surgery is almost never the primary answer.
Right.
Second, it involves this really complex skull-base anatomy that most other cancers don't touch. Third, the pattern of spread is unique. The retropharyngeal nodes are the default, not an afterthought.
And the fourth point.
And finally, it has a specific quantitative biomarker plasma EBV DNA that you are expected to use fluently for prognosis and surveillance.
So it really checks all the boxes for a high-level discussion. You have the anatomy, unique staging rules, and the integration of systemic therapy with radiation.
Exactly.
To keep us on track, we have 3 very specific goals for this deep dive. By the end of the session, you should be able to: 1, describe the anatomy of the nasopharynx in a way that actually predicts where the cancer spreads.
Which is key.
2, stage NPC cleanly using AJCC. 8 rules, and we want you to master the unique nodal rules that trip everyone up. And 3, explain why definitive RT, often with chemo, is the standard, and exactly how EBV DNA changes your counseling and follow-up.
Those are the pillars. Yeah. If you can walk away with those 3 concepts locked in, you are going to be in excellent shape.
Okay, so let's anchor this immediately with the case. This is a classic presentation, so I want you to visualize this patient.
Let's do it.
We have a 49-year-old man, originally from southern China. He presents with a 3-month history of unilateral nasal obstruction and intermittent epistaxis.
Okay.
He also reports a sense of fullness in his left ear, and he's noticed a mass in his left neck.
That is a textbook opening. I mean, southern China, the nasal symptoms, the ear fullness, that triad alone should be screaming NPC in your mind.
But there is more. He also mentions he's been having new headaches and intermittent diplopia double vision.
Oh, wow. Okay.
On your physical exam, you find a palpable left level 2 node. You note mild left serous otitis. And significantly, you find a subtle limitation of lateral gaze on the left side.
And that's it. That cranial nerve exam finding is the critical pivot point in this case. That changes everything regarding the T-stage.
Absolutely. So you proceed to nasopharyngoscopy, which shows an exophytic lesion in the pharyngeal recess. You biopsy it. The path comes back. Non-keratinizing carcinoma. EBER, or EBV-encoded RNA, is positive.
As expected.
You order an MRI, which shows the tumor is centered in the left fossa of Rosenmoller with parapharyngeal extension. It also identifies a left retropharyngeal node, plus the left level 2 nodes we filled.
Okay.
A PET-CT is obtained, shows no distant disease. And finally, his labs show that plasma EBV DNA is elevated.
Okay, that is a fully loaded case. So here's the prompt you might face in an oral board setting or even just from an attending on rounds. Stage this patient, tell me the treatment paradigm, and tell me what the big technical landmines are.
This is the moment where you have to switch gears from passive listener to active physician. I am going to run through a 60-second board script. This is a simulation of exactly how a resident should answer this prompt. It's rapid, confident, and structured.
Let's hear it.
Nasopharyngeal carcinoma is a radiation-driven disease with a high propensity for early nodal spread, especially to retropharyngeal nodes and frequent skull-base adjacency. I confirm the diagnosis with an endoscopic biopsy, obtain an MRI of the skull base and neck for T-stage, a PET-CT for nodal and distant staging, baseline labs, and pre-treatment plasma EBV DNA for prognostication. I stage with AJCC 8. T-stage depends on parapharyngeal involvement, bony skull base or sinus invasion, and intracranial or cranial nerve extension. Nodal staging uses size and whether nodes extend below the caudal border of the cricoid. Management is definitive RT with IMRT. Stage 1 is RT alone. Stage 2 is typically concurrent chemoradiation with selective de-escalation in low-risk IMRT-era patients. Stage 3 to 4A is concurrent chemoradiation, often preceded by induction chemotherapy in bulky or high nodal burden disease. I counsel on acute mucositis, xerostomia, hearing effects, and specifically the late risk of temporal lobe necrosis due to skull-base proximity, with strict OAR prioritization and MRI-based planning.
That was excellent. I mean, you hit the philosophy radiation driven. You
Mhm.
covered the workup, the staging logic, the treatment buckets,
Mm.
and you immediately flagged the safety counseling regarding the temporal lobes.
Right.
That is the standard of fluency you want to aim for. So now let's unpack this. Let's start with our first learning objective, anatomy that predicts spread.
This is where NPC really requires you to visualize the space. The nasopharynx isn't just a box, it's a junction. It sits posterior to the choanae, superior to the soft palate, and just inferior to the sphenoid sinus and clevis.
Exactly. But for the oncologist, the lateral walls are where all the action is.
Okay, why the lateral walls?
Right. We need to define the lateral boundaries because that is where the trouble usually starts.
Yeah.
The key landmarks you absolutely must know are the torus tiberius,
Which is the opening to the eustachian tube?
the cartilaginous opening, exactly, and the fossa of Rosenmüller, or the pharyngeal recess.
And this is a major board point. The fossa of Rosenmüller is the classic origin site for nasopharyngeal carcinoma.
It is.
It's located posterior to the torus tiberius. So this means tumors start high and lateral. Why does that matter so much?
It matters because of what is right next door. If a tumor starts in the fossa of Rosenmüller, it is immediately adjacent to the skull base foramina, like the foramen lacerum, the foramen oval, and the peripharyngeal space. It doesn't have to grow very large to cause huge problems.
I see.
We can actually map the symptoms our patient had directly to this anatomy.
Let's do that. It makes the list of symptoms so much easier to memorize if you understand the why.
Yeah,
So our patient had a neck mass.
right.
That one is straightforward. That's early nodal spread. NPC is famously lymphophilic.
Correct. But now look at the ear symptoms. He had serous otitis and a feeling of fullness in his left ear.
Okay, so that maps to the torus tiberius. The tumor expands from the fossa of Rosenmüller. It compresses or obstructs the eustachian tube.
And then you get fluid buildup in the middle ear.
Right. So clinically, if you see an adult with unilateral serous otitis, that has to be NPC until proven otherwise.
100%.
Yeah.
You cannot just send them home with antibiotics. You have to scope them.
Yeah.
It's a huge red flag.
Okay. Then he had epistaxis and nasal obstruction.
That indicates anterior growth. The tumor is pushing forward from the nasopharynx into the nasal cavity, or it's blocking the choanae. This is why patients often complain of stuffiness. It just doesn't go away.
And finally, the really scary symptoms. The diplopia, the headache, and that lateral gaze palsy.
That maps to the roof and the posterior wall.
Mm-hmm.
The tumor has invaded the skull base, possibly the cavernous sinus, or it's directly impinging on the cranial nerves.
A lateral gaze palsy specifically points to which nerve?
The sixth cranial nerve, the abducens nerve,
Ah.
right? The abducens nerve has this long intracranial course, and it runs right through the cavernous sinus, which makes it very vulnerable to compression or invasion in this area.
And it controls the lateral rectus muscle.
Exactly. So when it's paralyzed, the eye can't look outward. So just by listening to the history, you can already start T-staging this patient in your head.
That's a great way to think about it. Now let's zoom out to epidemiology and risk factors. Who gets this disease?
Yeah, NPC is actually uncommon in most Western populations. However, it is endemic in very specific regions.
You mentioned southern China?
Parts of southern China, specifically the Guangdong province, Southeast Asia, and North Africa. There's a clear male predominance. And globally, we're looking at roughly 133,000 new cases and 80,000 deaths annually based on GloboCan 2020 data.
And on the boards, they might ask about risk factors. What are the safe answers you need to have ready?
The big three you must name are 1, EBV association, especially for the non-keratinizing types.
Okay.
2, diet-specifically salt-cured or preserved foods, which are high in nitrosamines. This is particularly relevant in endemic regions where salted fish is a dietary staple from childhood.
And the third.
And 3, family history or genetic susceptibility.
What about smoking and alcohol? We talk about those for every other head and neck cancer.
They can contribute risk, of course. It's not a zero-risk situation. But unlike the rest of the head and neck, like the oral cavity or larynx, smoking and alcohol are not the dominant story here.
The dominant story is viral and environmental.
Exactly. which leads us perfectly into pathology. We mentioned our patient had non-keratinizing carcinoma. Why do we make that distinction?
So we generally divide histology into two buckets. First, you have keratinizing squamous carcinoma.
Oh.
This acts more like the typical head and neck cancer we're used to. It's more common in non-endemic regions, it's more linked to tobacco, and unfortunately, it tends to have worse local control.
And the second bucket?
The second bucket is non-keratinizing carcinoma. This can be differentiated or undifferentiated, and this is the classic endemic phenotype. It is strongly associated with EBV infection.
And clinically, what's the practical implication of that distinction? Why do we care if it's keratinizing or non-keratinizing?
The non-keratinizing EBV-associated type tends to be very radiosensitive. The tumors often just melt away with radiation.
But there's a trade-off?
There is. The trade-off is that they have a higher risk of distant metastasis compared to the keratinizing type. That is the long-term threat, and that's why systemic chemotherapy is such a huge part of the discussion for these patients.
Speaking of EBV, let's discuss the biomarker. Plasma EBV DNA. This isn't just a trivia point. It is a workhorse biomarker in modern oncology.
So how do we use it?
We use it in two distinct phases. First is at baseline. The pre-treatment level is prognostic. Higher levels of plasma EBV-DNA correlate with a higher tumor burden, a higher risk of distant failure, and just worse overall outcomes.
Is there a specific number we should memorize? A cutoff?
Well, in classic data sets, you'll often hear a threshold of around 4,000 copies per milliliter. But, assays vary between institutions. So on the boards, it's safer to speak in trends rather than absolute cutoffs unless you're quoting a specific paper.
Just high is bad.
High is bad. And then the second phase is post-treatment. This is perhaps even more important for the clinician.
Absolutely. We look at the kinetics. If plasma EBV DNA remains detectable after definitive therapy, say, a few weeks or months out, that identifies a very high-risk group.
And what does that suggest?
It suggests residual microscopic disease or maybe early metastatic spread.
But here's a nuance that can trip people up.
Yeah.
If you have a patient with persistent post-treatment EBV DNA, do you just throw more chemo at them?
This is a board-safe nuance you have to master. Persistent post-treatment EBV DNA is absolutely a risk marker. However, there is no universally accepted standard adjuvant therapy that clearly rescues everyone.
Right. There was that big trial.
Exactly. There was a well-known trial, EPNPC-01, that tried using adjuvant gemcitabine and cisplatin in patients with detectable post-treatment EBV-DNA, but it did not show a statistically significant survival benefit in that setting.
So what is the correct next step if you see that elevated level after treatment?
The correct answer is intensified surveillance and a discussion about clinical trials. You monitor them like a hawk, you scan them earlier or more frequently. You do not just confidently prescribe a toxicity-heavy adjuvant regimen assuming it will fix the problem, because the level 1 data isn't there yet to support that.
Excellent. That shows you understand the limits of the data. Okay, let's move to workup and staging. We're using AJCC8. Run us through the minimum diagnostic checklist.
You need a full history and physical, and you absolutely must document a thorough cranial nerve exam, specifically looking for those subtle palsies we talked about. You need nasopharyngoscopy with a directed biopsy to confirm histology. For imaging, an MRI of the skull base and neck with contrast is mandatory.
Why MRI over CT?
It's just the best modality for T-staging, specifically for seeing perineural spread or marrow replacement in the clevis.
Okay.
You also need a PET-CT for nodal and distant staging. You need baseline labs and baseline audiology, given the ototoxicity of our treatments. And, as we just discussed, baseline plasma EBV DNA.
Perfect. Now let's get into the weeds of staging. AJCC8. You don't need to memorize the table verbatim, but you must demonstrate the logic. So let's start with T-stage. How do you conceptually break this down?
I think of T-state as being pattern-based. T1 is confined to the nasopharynx, or it extends to the oropharynx, or nasal cavity. The key here is without peripharyngeal involvement.
So it can be big, but it has to stay in that central corridor.
Exactly. Then comes T2. This is a critical threshold.
Right.
T2 is defined by peripharyngeal space involvement and / or adjacent soft tissue involvement, like the medial pterygoid. This is a big jump because once you're in the peripharyngeal space, the tumor has broken out of the central box.
It's gone lateral.
It's now lateral, pushing toward the carotids and the styloid apparatus.
Okay, what about T3?
T3 is invasion of bony structures. So think skull base, clivus, cervical vertebra, or the paranasal sinuses. If the radiologist mentions clival marrow replacement or erosion of the pterygoid plates, You're in T3
Near
territory.
T4.
T4 is the catastrophic spread. We're talking intracranial extension, involvement of the cranial nerves, the hypopharynx, the orbit, the parotid gland,
So basically everything else.
or extensive soft tissue extension beyond the lateral pterygoids. If there is a cranial nerve palsy, it is T4 by definition.
So to recap, T1 is local, T2 is lateral into soft tissue, T3 is bone, T4 is brain or nerves.
That's a great way to put it.
Now, end stage, this is where people get confused because NPC rules are completely different from the rest of the head and neck. What are the gotchas?
The first gotcha is the retropharyngeal nodes, or RPNS. In NPC, RPNS count early. They can be unilateral or bilateral and still be N1.
And that's provided they meet the size criteria.
Right, generally less than 6 centimeters. In other head and neck sites, bilateral nodes usually bump you up to N2 or higher. In NPC, bilateral RPNs are just part of the standard early spread pattern.
That's a huge point.
Yeah.
If you call bilateral RPNS N2 on the exam, you will likely fail the station.
Agreed. The biology is midline, so bilateral spread to the retropharyngeals is biologically early for this disease.
And what's the major upstaging factor? What pushes a patient to N3?
The line in the sand is the caudal border of the cricoid cartilage. If you have nodes extending below the caudal border of the cricoid, or if you have very large nodes greater than 6 centimeters, that is N3.
And why do we care so much about the cricoid? What's the significance of that line?
Because disease below the cricoid, essentially reaching into the supraclavicular fossa, suggests a much higher burden and a very high risk of distant failure. It's a red flag for systemic spread.
I see.
Also, it's important to remember that in AJCC8, N1 disease in NPC still keeps you in stage 2 overall.
Whereas in many other head and neck sites, any nodal involvement immediately pushes you to stage 3 or higher.
Exactly. For NPC, early nodal spread is just so common that N1 keeps you in stage 2.
Perfect. So we've staged the patient. Now we have to treat them. Let's discuss clinical decision-making. First, the philosophy. Why don't we just cut these out?
Yeah, we have to say it plainly. NPC is not a surgery-first disease.
Yeah.
The primary tumor is in a location, the nasopharynx, where complete resection is morbid and, frankly, rarely feasible up front with negative margins.
It's just too deep.
It's deep, it's surrounded by critical neurovascular structures, and more importantly, the biology is highly radiosensitive. Outcomes are driven by definitive IMRT plus appropriately selected chemotherapy.
So surgery is for salvage.
Mainly for salvage of persistent or recurrent disease, not for the initial cure.
Okay, so let's walk through the evidence-based management by stage. Start with stage 1.
Stage 1 is T1N0. For these patients, definitive RT alone using IMRT is the standard. You do not need chemotherapy here.
And the dose.
The cure rates are excellent with radiation alone, usually in the range of 66 to 70 gray.
Okay, stage 2.
Stage 2 is where it gets interesting. Historically, randomized data supported using concurrent chemoradiation or CCRT over RT alone. The thinking was that even stage 2 had enough risk to warrant the chemo.
But things have changed.
They have. In the modern IMRT era, we have better local control and less toxicity. There is now credible evidence that for carefully selected low-risk stage 2 patients, you can treat with IMRT alone without compromising key outcomes.
So this is a de-escalation nuance. It's not a blanket rule, right?
Correct. You don't just give everyone RT alone. You have to look for low tumor volume, low EBV DNA, and favorable anatomy. It's a selection discussion you have with the patient.
So if they have high EBV or a bulky T2?
I'm still leaning towards CCRT, but if it's a small T2 with low EBV, IMRT alone is a very valid option to spare them the cisplatin toxicity.
Got it. Now, the heavy hitters. Stage 3 to 4A, locoregionally advanced disease.
The foundation here is definitive IMRT with concurrent cisplatin. That is the standard of care established by trials like the Intergroup 0099,
Right.
which famously showed a massive survival advantage with chemoradiation versus radiation alone, even though that was a non-endemic trial.
But we often add more chemo. Talk to me about induction. This is the current hot topic.
Induction chemotherapy is commonly used in patients with bulky primary tumors or a high nodal burden. A landmark modern example uses induction, gemcitabine, and cisplatin.
And the rationale.
This was shown to improve failure-free survival endpoints when added before CCRT.
So if you have a massive N3 neck or a T4 skull-based tumor, you're thinking induction.
Absolutely. Induction shrinks the tumor, which can have dosimetric benefits, making the radiation plan safer. But more importantly, it addresses micrometastatic disease early, The data supports it for high-risk features to control that distant failure risk.
And what about de novo metastatic disease, stage 4B?
Historically, this was purely palliative, but now, in selected patients who have a good response to initial systemic therapy, adding locoregional RT to the primary and neck can actually improve overall survival.
Hmm.
The concept is that chemosensitive metastatic NPC can benefit from consolidative RT. It's an aggressive approach for the right patient, typically delivering definitive doses to the gross disease.
Okay, let's bring this all back to our case anchor, our 49-year-old gentleman.
Let's reevaluate him. Histology, non-keratinizing, EBV associated. This means he's radiosensitive but has that distant risk. T-stage. The MRI showed parapharyngeal extension. That makes him at least T2,
Right.
end stage. He has retropharyngeal nodes plus level 2 nodes. So assuming those are above the cricoid and depending on laterality, he's likely N1 or N2.
So it's T2, N1 or N2, that makes him stage 2 or stage 3. What's the plan?
With T2 or greater and nodal disease, the standard recommendation is definitive IMRT with systemic therapy.
Okay, and if the examiner presses you, what would push you toward induction for this specific guy?
I would answer, if the primary is very bulky, if the nodal burden is high, like multiple large nodes, or if his baseline EBV DNA is extremely high, suggesting significant distant risk.
Right.
Those factors would push me to add induction gemcitabine and cisplatin before the chemoradiation.
And if they ask, do you ever treat stage 2 with RT alone?
I would say yes. In carefully selected low-risk IMRT-era patients, I'd justify it by looking at low tumor volume and low EBV biomarkers, but I would emphasize that I don't overgeneralize this to everyone.
Good. Now let's touch on technical considerations and toxicity. We aren't contouring today. That's the next episode.
Yeah.
But you need to sound safe. What are the big technical rules?
Rule 1, MRI-based planning is essential. You simply cannot see the skull base invasion or perineural spread adequately on CP alone. You have to fuse that MRI.
And rule 2.
Rule 2. NPC almost always requires bilateral neck treatment. Because it's a midline structure, occult spread to the contralateral side is very common. You treat both sides of the neck.
And what is the most important toxicity counseling point? The one you can't forget.
You have to cover the acute stuff like mucositis, weight loss, dermatitis, and the xerostomia, the dry mouth, which is chronic. But the big one for NPC late toxicity is temporal lobe necrosis.
Why is this the signature risk?
Because the target, the nasopharynx, is right underneath the temporal lobes. When you're trying to get a curative dose to the skull base, the radiation hotspots can creep up superiorly.
And temporal lobe necrosis is devastating.
It is debilitating. It causes cognitive changes, memory loss, seizures, and neurologic decline. You must tell the examiner, I will prioritize temporal lobe constraints, specifically Dmax and small volume limits while maintaining target coverage.
It creates a real tension in the plan, doesn't it? You want to kill the cancer on the skull base, but you can't fry the brain.
Exactly. And that's why techniques like IMRT or VMAT are mandatory here. You need that sharp dose gradient.
Don't forget the other late effects. Hearing loss from the cisplatin and cochlear dose, hypothyroidism, and even carotid stenosis years down the line.
Exactly. But temporal lobe necrosis is the one that shows you understand the unique anatomy of this disease.
Before we hit the quiz, let's summarize with some engagement tools. What are the oral board traps we need to avoid?
Okay, trap 1. Treating NPC like oral cavity with a neck. Do not propose upfront surgery for the primary. You will fail.
Right.
Trap 2. Forgetting the retropharyngeal nodes. If you don't explicitly mention RPN coverage and bilateral logic, you sound unsafe.
And the third one?
Trap 3. Misstaging the nodes. Remember, bilateral RPNS can still be N1. The below cricoid line is the major cutoff for N3.
Good. And board pearls to take away.
1. Fossa of Rosenmuller equals high lateral origin next to the skull base. 2. MRI drives T stage. PET-CT drives N and M stage. EBV drives prognosis. 3. Retropharyngeal nodes are core territory. 4. Stage 2 usually gets CCRT, but look for the de-escalation nuance. And 5. Temporal lobe necrosis is the late effect anchor.
All right, time for the board review blitz. I want to pose a question, and I want you to answer it.
I'm ready.
Question 1. A patient has a nasopharyngeal primary extending into the nasal cavity without parapharyngeal extension. Nodes include bilateral retropharyngeal nodes, all less than 6 centimeters, and a unilateral level 2 node above the caudal border of the cricoid. No distant disease. What is the nodal stage? Is it N0, N1, N2, or N3?
The answer is N1.
Why?
Because retropharyngeal nodes can be unilateral or bilateral and still count as N1, assuming they meet the size criteria. And the unilateral cervical node is also above the caudal border of the cricoid, which fits N1. To be N3, you would need extension below the cricoid or a node larger than 6 centimeters.
Spot on. Question 2. A patient completes definitive CCRT for stage 4A NPC. At 8 weeks, the PET-CT is equivocal locally but improving. Plasma EBV DNA remains detectable. What is the best next step?
Right.
Start adjuvant gemcitabine and cisplatin. B. Immediate nasopharyngectomy. C. Intensified surveillance and clinical trial discussion. D. Re-irradiate immediately.
The correct answer is C, intensified surveillance and clinical trial discussion.
Explain that.
Detectable post-treatment EBV DNA is a high-risk marker, absolutely. But the trial using adjuvant gemcitabine and cisplatin after CCRT did not demonstrate a survival benefit. Therefore, standard of care is not to just give more chemo, but to counsel on risk and monitor closely or enroll in a trial.
Last one. Question 3. Which statement is most accurate for stage 2 NPC in the modern IMRT era? ART alone is always equivalent to CCR. TB. CCRT remains standard, but selected low-risk patients may be treated with IMRT alone. C. Surgery is preferred. D. Induction is mandatory.
The answer is BCCRT is the historic standard, but contemporary data supports de-escalation with IMRT alone in carefully selected low-risk patients. It's all about selection.
Excellent job. That covers the essentials.
And that wraps up our intro to nasopharyngeal carcinoma, but we are not done with this topic.
Not at all. In our next episode, episode 22B, we're going to shift from concepts to execution. We're doing a target volume masterclass.
We'll cover how to contour NPCs safely. We'll talk about retropharyngeal node coverage, where to stop inferiorly. We'll discuss skull-based CTV logic, how to cover the foramina and the clavus.
And we'll talk about dose pinking and OAR prioritization to actually prevent that temporal lobe necrosis we warned you about.
Exactly. Today you built the mental model. Anatomy, EBV, staging, and the paradigm.
Next time, we build the plan.
Complete practice oral bores at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.